Well, we appreciate, Beth and I appreciate very much the opportunity to come and spend a few moments with you all today. The other thing that wasn't on Beth's resume that probably her biggest task is keeping me in line, which is no small task in and of itself. But the other thing, it's a little bit humorous about how we got here today. Shannon came to talk to me about the presentation and a little bit more about the organization, and I asked Beth to sit in because, you know, as general counsel, she deals with a lot of our ethical issues. So the three of us sat there and talked, Shannon had this wonderful idea that I immediately embraced, that Beth be part of this conversation today, so it not just be me. So thank you, Shannon, for that. That made it really a lot better. You know, the dialogue that your organization is creating around your guiding principles, I think, is outstanding. You know, the responsibility to self and others, leading with integrity, and inspiring trust. You know, what's not to like about all of that? So we're going to spend a few minutes today and share with you some of the things that we're dealing with, not just in healthcare, but we're dealing with as society, because I think that's very, very important for all of us to take away and to build into our conversations in our own businesses around everything that we do. You got the slides? So just a little bit of an overview. Nancy covered some of this, but INTEGRIS, who are we? We're basically an Oklahoma-owned and operated organization. We exist to improve the health of the people in the communities we serve. That's our mission. We aspire to be the most trusted name in healthcare. That's our vision statement. And I don't think it's any a coincidence that trust is in our vision statement and trust is in your guiding principles. We operate by the values of love, learn, and lead, and each of those have several components of them, and it's something that we stress to all of our associates across Oklahoma, and that's how we interact with our patients, their families, our providers, our vendors, and each other. And then our core competencies are delivering the most challenging healing through leading-edge clinical care, collaboration to create our future. We cannot be an island in and of ourselves. We have to collaborate with other entities. And then our community focus, and there's a lot of focus now on health and wellness, and we'll talk a little bit about that going forward. So what you see on the slide there are a little bit about our numbers. I'm not going to spend a lot of time with that. I think that's in your packets, but this is what we do. We're there to meet needs when they're needed the most. And with our geographic base across Oklahoma, during a year's period of time, we touch a large percentage of Oklahoma citizens in either an inpatient or outpatient, a clinical setting, an emergency department setting, and the like. Our centers of excellence are very, very important, and most of those reside here in Oklahoma City, and most of them on the Baptist Medical Center campus. That is our flagship facility, and that's where you'll see that highest level of care that basically is available anywhere in Oklahoma is available right there on that campus today. We are an integrated delivery system. We've got the full range of services in what we do. And we're moving much more rapidly from being hospital-centric to being patient-centric. About half of our revenues come from things that happen outside the four walls of one of our facilities. And that's happening all across the country and is going to continue to happen going forward.
So here's what we're going to do today. Can you hear me? Yeah, I can't hear me either. Did you not turn me on?
I don't know. We got this technical thing going.
Sorry, I've got this backpack I'm working with there.
Try that.
Can you hear me now? Yes. Oh, I didn't want to say that because that's that commercial. It's been overused. Anyway, okay, so now you can't hear me?
You went off.
Well, can I just yell? I mean, I'm good at that too.
Let's try again. Okay.
How about now? Oh, I just heard it. Okay, so here's what we're going to do today. We're going to follow the agenda right there. So basically, we're going to spend just a little bit of time talking and defining healthcare ethics as we see it, and also talking about the main ethical principles. But the bulk of our time will be spent today on access to healthcare and clinical ethics.
Okay, so starting with a definition I think is very, very important. And this is a definition for healthcare ethics. It'll differ a little bit from other industries, and you'll see why a little bit later on, but it's a set of moral principles, beliefs, and values that guide us in making choices about medical care. And that's very important because our ethical responsibilities in any given situation depend upon part the nature of the decision and the player that's involved. So what do I mean by the player that's involved? In our world, we have a patient or a customer. We always, or generally always, have a family member or family members, and sometimes it's multiple. We have the providers and multiple providers, and then we have the payers. And I guess I've gone out of, hopefully you can hear. So we'll just go with this. So patient, family, provider, and payers, and depending upon which role you play and the nature of what's going on depends upon the situation given. The other thing I'd like to just point out, ethics is not something new. If you go back and look, Aristotle in 350 BC wrote a book called Nicomachean Ethics. And in that, he talked about the rule of a leader is to create an environment in which all members have an opportunity to realize their own potential and to enhance their own power. Virtue and wisdom will definitely elude leaders who fail to engage in ethical analysis of their own actions. So this has been around literally since the beginning of time, the importance of ethics and how leaders approach their situations in an ethical manner. So once we have clarity around the definition, then we need to review certain principles around ethics. And in the United States, we have 4 major principles that are generally looked to in terms of healthcare professionals and what we owe our patients. The first one is autonomy, to honor the patient's right to make their own decisions. The next one is beneficence, to help the patient advance his or her own good. And then there's non-maleficence. I'd like you to say those 2 words 4 times real fast, which is to do no harm. And then the last one there is justice, to be fair and treat all cases alike. Now, in a perfect world, all 4 of those would be equally weighted and used together. But in the U.S., we tend to place more emphasis on autonomy than we do the other 3. The other 3 come into play, but looking out for that patient's autonomy so they can make their own decisions is very, very important in what we do. You know, we want to talk a little bit about access to health care, because in this country right now there's a tremendous debate going on about access to health care and what is appropriate and what should be appropriate. There's a tremendous debate going on about the number of uninsured people in America today. You know, the Patient Protection and Affordable Care Act was passed 5 years ago in March, so we've got 5 years of experience with that particular act. And one of the reasons that was put into place is because at the time there were between 40 and 50 million Americans without health insurance. Now, don't get confused. Some folks say, well, just because someone doesn't have health insurance doesn't mean they don't have access to care. And you're right with that, because if someone shows up in any emergency department in this country today, by law, we have to treat them. We have to see them, we have to do a medical screening exam, we have to determine do they have an emergent condition or not. And if they do, we have to treat them. We have no choice. We can't ask if they've got the ability to pay, we can't ask if they have insurance. We have to do those things, and that's required by law. So one of the things that the Patient Protection and Affordable Care Act was going to allow for our country was to allow that 40 to 50 million Americans to have access to an insurance product that really would give them access to primary care. And primary care is so important in the overall scheme of what we're talking about, because without primary care, people's conditions accelerate to a point where they do show up in an emergency department, their health condition is much worse than it would have been or could have been if they'd had good primary care. So the number of Americans without health care coverage has gone down a little bit in the last 5 years, The Patient Protection and Affordable Care Act has been challenged once already by the Supreme Court. There's another challenge going on right now. We should get a ruling this summer. That one has to do with the subsidies that are provided by that to help folks be able to buy that insurance product. Our goal here today is not to talk pro or con for that particular act. You know, my personal opinion is there's some good things in the act and there's some not so good things in the act. But the point today is just to raise the question and the awareness around access to health care. And is that truly an ethical question that not those of us in the healthcare industry should be asking, that society should be asking? You know, the Pew Forum did a study back about 5 years ago, and out of that study it said that most Americans understand that 72% of the population thinks that our society should ensure universal access to health care. Now don't get confused. I'm not talking about universal care, which is a one-payer system. I'm talking about universal access to health care. Also, 60% considered it to be a moral rather than a strictly political or economic issue. So this was a study done several years ago that highlighted that. So that's why the improving access to health care is so very, very important.
Okay, so let's take a look at what are the core values that are at stake here. As Americans, what are the things that we value the most? We value equality of opportunity, we value justice, and we value compassion. So let's take each one of those separately. We all know that equality of opportunity is compromised when we have identifiable subpopulations of our society that are disproportionately affected by limited access of care. We know this because we can actually measure it. And these consistently show us and demonstrate that it leads to poor health outcomes specifically related to racial and ethnic groups, because we can measure that. And then what do we do about it? So how does that relate to, like, a business decision, for example? So ask a question. Look at us as healthcare. Look at us as a healthcare system. Should a healthcare system feel conflicted about dropping its low-paying insurers, even though we know that there may be a very large group of long-term, very loyal patients that would be affected? And in the end, does it come down to being able to pay the bills and to keep the doors open? Those are things that we have to grapple with every day. Justice. Think about justice. It demands that we look at a fair allocation of our resources toward our vital needs. Inadequate social investment into things like education, environmental protection, nutrition, housing. We know that what ends up happening is it reduces the health of our population. How do we think about that at INTEGRIS? Just as Bruce said, we offer the full range of services. We offer transplant services. So you have to look at it, we have to look at it from the standpoint of allocation of organs from a transplant standpoint. What do you do when you're making a decision between a 17-year-old that may have comorbidity? And what I mean by that is a 17-year-old may be a diabetic versus a very healthy, vibrant 69-year-old that is vying for the same organ. Compassion. We all feel compassion to the least fortunate who don't have access to health care. How does this play out? They don't see a physician when they need to see a physician. They don't take their children to physicians because they can't afford it. They're not getting the vaccinations. They're not getting the flu shots. And then what ends up happening is when they finally do seek health care, it's usually critical. And by the way, all the examples that we're going to talk about today are all very, very real. So let me lay this one out for you. A single mom of a 17-year-old. She lost her husband to cancer 2 years ago. When she lost her husband to cancer, she also lost her insurance and her access to insurance. Then the unthinkable happens. Her son, her only child, ends up with having an accident, a skateboard accident. He hits his head. He comes home, he tells his mom, look at my bruise, whatever, they have dinner. It goes through her mind. Well, should I have him looked at? Should I take him to an emergency room? And then she thinks, I don't have insurance. I can't afford to answer those questions. But then she thinks, but he's okay. He's talking to me. We had some dinner. He ate. Everything's fine. He doesn't wake up the next morning. Very, very real. She didn't take him to seek medical care because she didn't think that she can afford it. She didn't know how she was going to pay for it. So that's how that plays out in our world.
So just so you don't think that access is new, in 1946, the World Health Organization basically came out with this statement you see on the screen, that the enjoyment of the highest standard of health is one of the fundamental rights of every human being without distinction of race, religion, political belief, economic, or social conditions. So our world was a whole lot different back in 1946, but people were still thinking about access to health care as being vital at that point in time.
So to that end, in 2007, the Ethical Force program was initiated by the American Medical Society, and this was a really cool initiative. The reason why is the AMA brought together a very diverse group of stakeholders. I mean, they came from all walks of life, but their purpose has always been to focus on healthcare performance metrics, quality metrics, research initiatives. But this time what they did was they said, okay, let's take a look at and overlay on top of all those decisions. Let's talk about ethical obligations and how that would play out. Did I move this? Yes, I did. Okay, so the first one is for every member of society must have an adequate array of core healthcare benefits. So but the obligation of the core ethical values were just what we just discussed. What they held close were those American values of compassion, justice, and equality of opportunity. But this time they also said, you know what? It's also supported by economic, political, and social considerations at all. I would submit to you, though, that the operative word in that sentence is core. So what this group said was basically that core doesn't mean that every American gets access to every conceivable treatment. But what it does mean is that when we are all thinking about reform plans, when we're considering policy changes, we need to address and we need to have front of the mind awareness of the interrelated concerns of access to care, quality, and healthcare costs.
So the second is the contents and limits of healthcare benefits must be established through this ethical process. There are 5 major tenets of that. It has to be transparent. The process of designing and administering health benefits should be fully transparent to those affected by the process. They have to be participatory. Organizations should purposefully and meaningfully involve all stakeholders in creating and overseeing the process of designing and administering the health benefits. They need to be equitable and consistent. You know, Beth had talked about that a little bit earlier. These benefits should result in similar decisions under similar circumstances. Also sensitive to value. The benefits should take into account the net health outcomes of services and technology under consideration and the resources required to achieve these. And I'll talk a little bit more about that in a moment. And then compassionate. They should be flexible, responsible to individual values and priorities, and attentive to the most vulnerable of those that we take care of. The third is the healthcare system must be sustainable. And this is an area where we hear a lot today in the dialogue that's going on in our country. And you know, the percentage of our gross domestic product that goes to healthcare today is approaching 18%. And some would say that's a way too high number. It shouldn't be near that high. I don't know if it's a too high number or not. I know it's about $2.3 trillion in healthcare spend. That's across the entire continuum in our country today. We've got to be careful and balancing to make sure that there's not so much that goes to health care that other services get denied. And so I think the dialogue happening in the country right now is looking not at how much of our GDP is being spent on healthcare, but what's the value we as a society are deriving from the money that's being spent on healthcare, and is it providing that value? You know, one of those areas, and Beth will talk about a little bit, is end-of-life care. If you look at the Medicare population today, you know, 85 to 90% of all healthcare dollars in the Medicare population today are consumed in the last 60 days of someone's life. And so that's a dialogue that as a society we need to be able to have. We need to be able to sit down and ethically discuss what are those things that we need to be doing at the end of someone's life. And is it absolutely necessary that we continue to do all of those things at the end of one's life? That's not a discussion just for the healthcare provider. That's a discussion for the patient, for the family, and really for society. And there's not a politician that's elected today that wants to have that conversation. It's a difficult conversation, but it should be a difficult conversation, but it's one that we need to have. And then fourth, the healthcare system must ensure that its stakeholders have clear responsibilities for which they are accountable. You know, personal accountability is something that impacts dramatically the resources that are consumed in this country on healthcare. If you look at the major disease categories that we see in Oklahoma and really are seen across the country, and they're very similar, and if you haven't seen, I would encourage you to look at the state of the state's health for Oklahoma. The health department does a report every year. Our state of the state's health is very, very poor. Now, we're better than we were about 5 years ago. We were 49th 5 years ago, and 49th's not good. I think we've moved up to 45th or 46th. I'm not sure we've gotten much better, but maybe we haven't gotten any worse. Now, think about if, and not to play favorites here, but if OU, OSU, and TU all had football programs that were in the 50th percentile, would we be happy with that? Absolutely not. Coaches would get fired. I mean, things would happen. But we have gotten comfortable in accepting this level of our state's health. And again, that's not just our responsibility on the provider side, that's society's responsibility. But of those conditions that we treat, there are four things that could have a huge impact on that gets back to personal responsibility. Diet, activity or exercise, the use of tobacco, and the use of alcohol. Those four things impact the majority of everything we deal with on the provider side. And that gets back to that personal accountability. And Nancy and I were talking at lunch before we got started. These are things that are going to take generations to change, but we've got to start somewhere. We've got to start with our youth today. The overall health of youth in Oklahoma and youth in America today is worse than it's ever been. Type 2 diabetes didn't even show up in adolescence until about 10 or 15 years ago. That was something that someone got late in life. Now we have kids that are 8, 9, 10 years old with type 2 diabetes, facing obesity, and all the things that go with that. So personal accountability has got to be something that we all are working on. And there's an author that's written a book. His name's Norman Daniels, and the name of the book is Just Health. And he makes a comment in there that I thought was really fascinating and very much on point, is that healthcare itself often arrives too late onto the scene. A better approach of health requires preemptive action of wellness programs, screenings, and environmental health. And there are some things happening in central Oklahoma right now to this point. Gary Cox, who's head of the Oklahoma City County Health Department, and his team are doing some remarkable things to try to get the improvement in health, wellness, screenings, activity, nutrition going for the population in central Oklahoma. And I know there are other efforts in other communities across the state. We've got to start there because that definitely impacts everything that we're doing.
So when you take the 4 ethical obligations that were set forth from the Ethical Force program, let me give you a couple of scenarios. that we have to deal with that this implicates. Long-term care patients in an acute care setting. So you have a patient that's exhausted all of its payer sources. They no longer meet the criteria for inpatient stay, but they're too acute to be able to go to a nursing home, a skilled nursing facility. So what do? They require 24-hour monitoring because either from a family member or from a nursing assistant, because they continue to either pull out their trach or pull out their IVs, and so they have to have somebody that watches them 24/7. So what do you think about doing? You think about as a hospital and a healthcare system, you don't own the skilled nursing facility, but you consider paying for the 24-hour monitoring, because guess why? It's a lot cheaper than continuing that stay from an inpatient standpoint. And you all would be shocked the number of patients that we have, and I would tell you that it's at all of our competitors as well, that have patients that have length of stays that are 100 plus days, because there are no options out there for them. That's one. The other one, so let me bring this a little closer to home. The employer-employee benefit situation. So you have 5,000 employees, and your healthcare costs from an organization standpoint, when you compare it to national metrics, you're actually doing pretty good. You feel pretty good about it, with the exception of you've got 7 employees that account for a huge percent of those healthcare costs. And primarily because they all have chronic hepatitis and they take very, very expensive drugs. So during your next plan review, when you're planning for your health plan, do you give any consideration to not covering those specific hepatitis expensive drugs? And does your answer differ if you're a healthcare system and you're in the business, so there's a higher expectation that you would continue those drugs? And by the way, one of the things that Bruce didn't say in his introduction is we're not here to give you any answers. We're just here to kind of lay all this out for you.
To raise the question.
We're just raising the questions. And I'm going to give you another scenario that I didn't put on the slide because it looks like we're doing very well on time and I've had a lot of, in fact, this was one of the things that we talked about with Shannon when we visited with her about doing this, and I have a lot of physician friends, and I've had a lot of these kind of debates with them as well. So let me pose another question for you. Would a physician overstate a patient's condition to either get treatment covered or to maybe just extend it a little bit longer so that maybe the spouse that's at home needs a little bit more time to prepare the home to bring her or his spouse home? Yeah. I'm kind of thinking, yeah. I mean, these kinds of things play out every single day, and they go through physicians' mind. They go through hospital administration's mind constantly. So these are strong ethical considerations when we're talking about and discussing access to care. So basically, when we're all in the throes of making policy decisions, whether it's in Washington, D.C., or whether it's our state legislature, or whether it's even us and you all as employers and as healthcare administrators, the bottom line is you've got to look at access to care, quality, and cost, and never forget one thing. For us, it's all about what's happening at the bedside. How do these policy decisions, how are they going to play out at the bedside? And that's why we have laced and will continue to lace the remainder of our presentation with scenarios, because they're very life scenarios. And I have a feeling that if I asked for a show of hands, even the ones I've already mentioned would resonate with many of you in the room. So now we're going to shift to clinical ethics, and I've got to be very transparent here and tell you I'm starting to get into my wheelhouse here. And what that means is I have a tendency to get a little animated when I start, and that's what got me into trouble, by the way, and I got asked to be up here at the table. So anyway, because I do get excited about this, and I want to give one caveat because I know we have some attorneys in the room too. And it's not a legal presentation. And a lot of times I get tons and tons of calls that bleed legal and bleed ethics. And being a nurse, I will tell you, and I know this is being taped, and I shouldn't say this on tape, and I'm going to probably regret it later, but being a nurse, I don't automatically, sorry all my attorney friends, but I don't automatically go to the law. I go to what's happening at the bedside. Because every single dynamic, when you're talking about, see, I got already ahead of myself. So when you start talking about these big issues, you can surround yourself and cover yourself up with the law. But the bottom line is you're affecting people's life at the bedside. So when you think of healthcare ethics, most students and most people I talk to about healthcare ethics, guess what they say? They automatically go to those areas that garner the most media attention. And those are your top three up there. They're the life-sustaining treatment, the end-of-life type decisions, euthanasia, and abortion. Those are the ones you're going to see in the Wall Street Journal. Those are the ones that you're going to see if you pick up a People magazine or even play out in the Daily Oklahoman. So everybody in this room, now I'm making a big assumption here that you're all competent adults. I'm making that assumption. So everybody in the room has the right to refuse treatment. But I'll bet you, if we went table to table, your reasons would be very different. Some of you might refuse treatment for religious reasons. Some of you might refuse treatment because you think that the procedure is too risky. Others might say, it's too expensive, I'm 82 years old, and I want to leave my children some money. Others may say, you're prolonging my dying, and I'm okay with that. But you know the one I hear the most? The one I hear the most is, it's affected my quality of life. I'm not going to live this way. That's the one I hear the most. So, but let's throw a little ethic questions in now with that. So, you have a patient. We're all competent. You're competent. We have a patient that refuses. You decide that you're going to refuse treatment. There are some people that would say you're committing suicide. Then if you have an advance directive, which I'm going to talk about in a second, and your healthcare proxy, you're out of it by now. Now nobody in the room is competent. Your healthcare proxy makes the decision. I've actually had people say to me, clinicians say to me, well, they're making the decision to, pull the tube, pull the plug, but is that murder? Is that murder? And then what about the states? And I think there's 4, but I could be wrong. I think there's 4 states that allow physicians now to prescribe medications to hasten the death. And is that suicide or murder through euthanasia? Okay, no answers for you, but that's what you can do. And I'm leading into the advanced directives right now. So basically, how many in the room have an advanced directive? That's pretty good. That's pretty good. You noticed I didn't raise my hand. Isn't that terrible? Anyway.
That is terrible. So it's do as I say, not do as I do.
Yeah. Yeah. So, but advanced directives basically takes the guesswork out of what you want. So your family knows what you want. Your clinicians, your providers, everybody knows what you want. So we highly encourage, and the advanced directive that you received in your packet is the advanced directive that it follows Oklahoma law, but it's the advanced directive that the attorneys at INTEGRIS Health use. In fact, we're doing fairs right now. Once a year we go out with our employees, and because we obviously offer them to our patients, but we also bring this education to our employees as well. So I would highly encourage you to have that discussion. Why don't we have that discussion? We don't typically have the discussion because nobody wants to talk about death. Nobody wants to talk about mom dying. We were talking about this at our table. Nobody wants to talk about death, but we're all going to die. So the best thing that we can do for our family and providers is to let them know what we want. Take out that guesswork.
So Beth, let me ask you a question.
Oh, this is not planned.
So do we ever see providers that look at an advanced directive and really start to question whether or not they should adhere to that? And does that create some dynamics sometimes with family members?
Oh my gosh, absolutely. In fact, that is one of the scenarios that I was going to talk about. We have many times and many occasions where and I'm gonna use Nancy's word, where family members don't want to let go of grandma, Poppy, mom, dad, and so they try to override the advance directive. They try to put forth, I hate to use the word evidence, but they try to say, you know what, when Poppy filled that out, 10 years ago, but the bottom line is we know because he told us recently. Well, we don't know if they're lying or not. We have no idea if they're lying or not. We've got a valid advance directive. So yes, that does play out with some frequency.
Well, even with providers too. I'll give a case. My father, 5 years ago, had an advance directive. He was very clear. He didn't want any extraordinary measures done. He had emphysema, had been suffering with that for several years. His quality of life had gone way down. He was not happy, and it was just one more episode of pneumonia was all he basically had left. So he was in the hospital over in Arkansas. I know his doctor well. He knew our family well, knew my dad well, and he walked in and he said, okay, I think we need to put him on a ventilator and move him to ICU. And I looked at the doctor and I said, that's not what he wanted. Well, I know, but if we don't do that, he's not going to live through the night. And I said, but doctor, that's not what he wanted. You know that. You and he'd had that conversation. He said, yeah, I know, and I know you got the advance directive. And I said, so what if we did put him on a ventilator and moved him to ICU? What kind of quality of life would he have? How long would he last? He said, I'm not sure, maybe 7 days, maybe 10. And I said, and with no quality of life. I said, that's not what my dad wanted. And so, fortunately, my dad had spelled it out. My mother was in agreement, and the ventilator wasn't put on, and he passed away peacefully the next morning. But if we hadn't have been standing there, even with that advance directive, I'm afraid he'd have been put on the ventilator vent and moved into ICU. So very, very important to talk to your providers and make sure they truly understand and know, yes, this is what's on paper, and yes, this is exactly how I want it to happen.
And we've had that play out on many occasions, and I know there's physicians in the room, and I've asked physicians, why do they feel that way? And why sometimes do they take that approach? And you know what the answer was? And it really was a consistent answer. They're scientists, they're smart, and I have had many physicians say, Beth, I see it as a failure. I see it as a failure because my job is to keep them alive. To keep them alive and to keep as much of a quality of life as possible for them. So the physicians are people too, and are humans too, and they grapple with the same issues. So that's an excellent point. Let me, I don't want to run out of time. Let me give you a couple of scenarios how these things play out with us. To Bruce's point about families and families trying to override, we had a 77-year-old patient that came in with a brain tumor. He agreed, it was a very risky surgery. He knew that even with excising the tumor that he might not make it. And sadly, what ended up happening was he did make it, but he was in a persistently vegetative state. And the physicians moved forward to implement the DNR, and the family had a fit. This individual did not have an advance directive. But, and I don't want to go into the law here, the physicians could have done what they wanted to do. But again, from a compassionate standpoint, you've got to work with that family. Very aggressive family. Daughter went to court, daughter got a guardianship, and then demanded that her father get this life-sustaining treatment. And they ran out of money. So who's going to pay for $27,000 a day? And the physician knew that there's no way they could afford that. Let me give you one.
Can I add a little bit something to
Sure.
that? So I had a situation many years ago, very similar, except it was a young person involved in a motor vehicle accident, brain injury, basically was determined, was brain dead, was not going to survive. The family said, no, we believe in miracles, we think it's going to happen, and they still had some insurance, and so we did what the family wished. rocked along about 2 or 3 weeks. That benefit ran out. And so we went to the family and said, okay, your benefit has run out, and they knew that. So now it's, and I don't remember, say $27,000 a day. It was amazing when they thought they were going to be on the hook for that. Okay, it's time to say goodbye. So that gets back to that little bit more about that personal accountability. You know, if you're spending somebody else's money, it makes it real easy. I worked for a guy one time, said, you know, if you're not going to pay for it anyway, you might as well go first class. And that's kind of the way our healthcare system has evolved through the years, because with insurance payment, there's been very little out-of-pocket payment. And we're going to see, we are seeing a major shift in that today going forward.
Mm-hmm. And you know, it's sad, I wasn't going to bring up the money piece, but you know, every dynamic, you take one patient with a brain tumor and another patient with the exact brain tumor with the exact outcome, you're going to have a total different family dynamic. That's why as healthcare providers, as case managers and physicians and bioethicists and legal counsel, you know, whatever, you really have to, you've got to immerse yourself in and try to understand the intent and what the family, and get to know them. And that's one of the things that we really, really strive to do, because once you can understand a motivation, then you can figure out a path. I think that part's a great message. That was totally off script. Let me give you one more example. So we had an adult male come in, and he's got diabetes, and he has gangrene on his leg. He has an open wound, gangrene, and he wants to leave. He's okay with it. He says, you know I'm dying. This treatment is too expensive. I just want to go home, and I want to die in my house. Well, the doctor explained to him, you're going to die a very painful death if you don't want any of these medications and any of these treatments. He insisted, so everybody thought he was crazy. Because how would you go home? Okay, maybe I should pull the roof. I won't. But just think about it. Would you go home with a gangrenous leg? We truly had this situation. So the physician orders a psych consult, thinking that this individual is not competent. Has the psych consult, it comes back, yeah, he's very competent. He just wants to go home, and he wants to die in his bed. And that's exactly what he did. He went home and he died in his bed. There were some clinicians that said, Beth, did he commit suicide? Did we let him commit suicide? So these, and I could give you more and more scenarios, but I'm not, because we're going to get short on time, and I want to hit something that I think is very important. So those are kind of the big rocks. You know, the ones that garner that media attention. So let me take you to a little bit more subtle level that people don't give a lot of thought to. I didn't make this up. Bioethicists in the last couple of years, they've started to take a deep dive into what they call, oh, it's not working. Well, this is a good day. There we go, there we go. Oh, now we go back. Okay, microethics. Very interesting, very interesting. So you've got those big rocks, but these little clinical ethical decisions, they play out in different ways every single day on a very subtle level. So things that you might not even think about. So let me give you an example, two examples, quick examples. Anesthesia. Probably just about everybody in this room has been under anesthetic, right? Well, you know that when you go under anesthetic, if you didn't know, I'm not trying to scare you, but you know when you go under anesthetic, you could die. You might not come back to us. So all anesthesia carries a risk of death. Even if you're going in to get your gallbladder out, or you're going in to get your appendix out, or a tonsillectomy, or whatever. Some anesthesiologists never mention it. Some mention it all the time. But then you have others that basically their approach, they customize their approach depending on how they think the patient will receive it. So if they think you're a little wackadoodle, they're not going to tell you. If they think that you know, you're this straight-laced, you know, then they're probably going to tell you. But and so basically, these are now called relational judgments. And these relational judgments are being framed in the last couple of years by bioethicists as ethical decisions. They're really constant little ethical decisions that play out in our physician offices and our clinics every single day. So very, very individual, very individual. And I would submit to you that most clinicians, sorry doctor, but most clinicians probably don't give it a whole lot of thought. And you know why? Just like everybody in this room, you do behaviors over and over and over. Guess what it becomes? A habit. So you don't think about it anymore. So I would tell you that probably people don't think about it. One more example, and then I'm almost done. But I think this is a really important one too. Is it ever okay? Is it ever okay to withhold information for therapeutic reasons? Okay, Shannon says yes. Now let me pose this question. You don't know I'm going to do this.
I don't know what you're going to do.
Well, he put me on the spot. I'm going to put him on the spot. So Bruce, you have a chronic condition, okay?
I didn't think you knew. Who talked?
Well, it's a HIPAA violation, but yes, we won't go there. So your physician comes to you and he says, you know, Bruce, I've got this great drug. I got this great drug and I'm telling you it's going to make you feel better. But he also knows that you're kind of sensitive. So he doesn't want to tell you that you have less than 1% chance of impotence. Wait for it. So
this is a trick question.
I'll answer it.
So for those of you that don't know,
I'm going to die.
Totally unplanned, but that was Donna, his wife. But the physician has read a plethora of research about the power of influence. So he or she bases his or her subtle contextual things based on the relationship and what he knows about his patient. So these things play out every single day. And to me, it's absolutely amazing. And I'll say one more thing, and then I turn it over to Bruce to conclude. But I would even tell you that it's not just your physicians, but it's probably everybody in this room. We look at life through the lens of our own experiences, our biases, and our prejudices. Physicians and clinicians are absolutely no different than everybody in this room. So how you put things into context from a leadership standpoint, from a physician standpoint, will have an impact on the person that's sitting in front of you. Thank you.
So, is wackadoodle a clinical or a legal term? I liked it. I just didn't know which one it was.
See, I just get animated. Sorry.
So hopefully that helped to give you some perspective of some of the things that we deal with on our side. So I want to talk just a little bit about clinical ethics and how does it actually function. And in INTEGRIS, we have an ethics committee. We do have a bioethicist that's on our staff, a very bright young man. We just added him a couple of years ago to our organization. We have physicians, case managers, nurses, others that are trained in ethics, and so it's a very, very important part of what we do. Always start with those same core principles that I mentioned at the start of the talk around autonomy, beneficence, non-maleficence, and justice. The framework itself has 6 components. Information, which we've got to obtain as much information as possible about the situation. The patient's medical condition, their social condition, their psychological condition, their spiritual condition, everything we need to know in that information. Then we need to identify and assess, is this an ethical issue? Is it a legal issue? Or is it something that another area needs to be involved with, such as another service or department within the health system? Then we have to clarify, we have to determine what type of ethical issue it is, ensure that all parties know. And so again, the transparency piece of that is incredibly important. The assessment, we evaluate all bioethical considerations, the patient's preference, their interests, their values, their contextual aspects. We have to talk about the benefits, the harms, the risk. All of that has to be, again, incredibly transparent. And then we need to advise when necessary. Because a lot of times someone will seek an ethical consult and they're wanting to know, you know, help me understand, help my family understand, help my provider understand. And anyone can ask for an ethical consult. The patient, a family, a provider can do so. And then all of that has to be documented clearly and kept, and we do review those. Our ethics committee reviews every ethical consult, as does our human values committee at INTEGRIS. So hopefully this information that Beth and I pulled together at a high level, and then by drilling down into some actual scenarios, gives you a little bit clearer understanding of what we deal with on a daily basis, sometimes an hourly basis, if you take an organization the size of ours. We also hope that you see out of this that a lot of these issues aren't healthcare issues originated. They're societal issues. They're family issues. They're relational, as Beth said. They're customs. They're values. All those things come into play there. And that's what makes it so difficult, but I would also say it makes it so exciting, because being able to have that level of conversation and to open people up and allow them to talk through, maybe for the first time, what their true beliefs are about their own life and how they want to live their life or how they want to end their life, is very, very powerful, and it's very, very important. And I think those of us in the healthcare field view that as a responsibility that we do not take lightly, and it's something that we put a lot of emphasis on. So thank you so much for your attention to this. We've thoroughly enjoyed this, and I don't know if there's time for questions or not, but I'm going to turn it back over to Shannon. Thank you.